Hello, my name is George Netto. I'm a professor of pathology, oncology, and urology at Johns Hopkins University. It's been a pleasure to participate in this very well-attended conference. Some of the topics that I presented involve molecular progress on prostate cancer. As many of you are aware, a big controversy right now in prostate cancer management is whether due to aggressive screening with PSA testing, are we really over-treating some patients, and are we doing more good or more harm? Of course, there are some patients that should really be treated, but there is potentially a large proportion of patients that could benefit from active surveillance. The key is, though, how to decide on the molecular level who are the patients who should be treated because they may have potentially lethal disease versus those who have insignificant disease. Clearly, clinical and pathologic criteria will help in this, but the progress that has been accomplished in the molecular field has finally paid off some dividends, and we believe at this time that some of the markers could be ready to start helping with this issue. A couple of the markers that I discussed were tumor suppressor gene P10, the master suppressor gene of the mTOR pathway, and I think now there is enough evidence that loss of P10 has a power to predict not only biochemical recurrence, but even evidence for time to metastasis and lethal disease. In our institution, we started, at least in the setting of patients who are assigned to active surveillance, perform P10 on a regular basis on cases with Gleason grade 3-6 in order to identify those who have loss of P10 and potentially would not be the best candidate for active surveillance. Of course, all these markers should be taken in consideration with the rest of the clinical pathologic parameters. Another marker in combination with P10 is ERG, and that signifies the TMPRSS-ERG fusion. And now, given that this marker can be done by immunohistochemistry, one is able to couple it with P10 and try to help in the classification of risk of these patients. The new genome-wide studies, of course, have helped discover additional markers and some signatures. And I also touched upon some of the commercially available new genomic tests that I picked 3 of them to discuss to the group, which are Oncotype DX, Decipher, and Prolaris. I had no affiliation or interest in any of these tests, but these are the most commonly used tests or being ordered by urologists in our institution. And I discuss the potential strengths and value of some of these tests and some of the need for further analysis and further studies, especially prospective studies, for these tests to be further validated. Thank you very much. I appreciate the opportunity.